Welcome to Malpractice Podcast. Hey Mal Pals. So today's episode is going to be just a little bit different from our usual, as Jess is dealing with the loss of a family member, so today it's just me. I'm Sydnee, and if this is the first time you're joining us, welcome to Malpractice. This episode is going to continue our series celebrating Black History Month, and today we'll focus on the history of the Tuskegee Syphilis Experiment. We also have an incredible guest, Dr. Tina Sachs, who's a professor at UC Berkeley. Her award-winning research focuses on racial inequities in health, and she has a very interesting perspective to present about the Tuskegee study. So we're also super excited to hear from her. Before we hear from Dr. Sachs, I'm going to walk you through what the Tuskegee Syphilis Experiment was. So between 1932 and 1972, the United States Public Health Service conducted what is considered today to be one of the most infamous and ethically problematic biomedical studies in American history. In 1932, the Public Health Service, or PHS, in collaboration with the Tuskegee Institute, which is now Tuskegee University, a historically Black college, began the study to record the natural history of syphilis in the area and to justify treatment programs that focused on Black communities. Investigators in the study enrolled 600 poor Black sharecroppers in Macon County, Alabama. 399 of these men were diagnosed with syphilis, and 201 did not have syphilis. So the plan was to treat those without syphilis as the sort of control group, and to treat those with syphilis as the experimental group. All of the men who participated in the study were promised free healthcare and survivor's insurance as an incentive to encourage their participation in the study. The men who had received a positive syphilis diagnosis were told that they were being treated for it, but no one was ever given the opportunity to give their informed consent, in part because they were being lied to about actually being treated for their illness. Before we get into the history of the study in full, I want to talk for a minute about syphilis itself. So, syphilis is classified as a sexually transmitted infection, but it can be spread in many other ways, and it's caused by the bacterium Treponema pallidum. And the symptoms vary depending on which of the 4 stages the patient is in. The first stage is going to start with a single, relatively painless genital ulcer, followed by a diffuse body rash that can be itchy and painful, and that usually starts in the second stage. This stage may be accompanied by sores in body cavities like the mouth. The third stage is latent syphilis, which can last for years, and there are generally no symptoms during this stage. The 399 men recruited for the Tuskegee study were all in the latent stages of syphilis. After the latent stage, by the tertiary stage, patients may experience growth all over their bodies, neurological symptoms, and heart problems. Syphilis may also attack the central nervous system, and it can cause meningitis, cranial nerve palsy, acute ocular issues, so difficulty with vision, and even paralysis, as well as several neuropsychiatric issues like dementia, psychosis, and depression. If left untreated, syphilis can even cause death. After the first 6 months of the study, the PHS had its funding cut, yet they continued to study the men without informing them that they would never be treated for their illness. Researchers told the men participating in the study that they had, quote-unquote, bad blood, which was a local terminology used to describe a variety of issues, including things like anemia. In 1934, 2 years after the study began, papers began being published describing the horrifying health effects of untreated syphilis. So the doctors participating in this study knew about what would happen if syphilis went untreated. Shortly afterward, the researchers involved made the decision to carry the study out for the next 40 years based on the idea that they would follow each of the participants until their death. When the study began, there were no proven treatments for syphilis. However, by 1947, with the study still in full swing, the antibiotic penicillin became the accepted standard for treating syphilis patients, and it became widely available. At this point, the PHS knowingly withheld medical treatment from both the experimental and control groups. So even though penicillin was available, everyone knew it was effective in treating syphilis, they chose not to give it to their patients. Shortly afterward, the PHS even established rapid treatment centers to treat syphilis by distributing penicillin, but they deliberately chose not to treat the men participating in the study. Now, if you're anything like me, you're probably thinking, how is this even possible? And within, most of our parents' or grandparents' lifetime, how is it possible that people knowingly chose to refuse to give these people treatment, full well knowing what syphilis would do if left untreated, and no one knew about it? And the problem isn't that no one knew. The problem is that many people in positions of power knew what was happening and deliberately chose to let it continue. The American Medical Association and the National Medical Association officially supported the study as of 1969. Many others publicly voiced their interest in and support for the study. Concerns weren't raised about the ethics of the study until 1966 by an employee of the U.S. Public Health Service named Peter Buxton, who filed an official protest with the PHS's Division of Venereal Diseases. But his protest was rejected on the grounds that the study had not yet been completed. He went on to file multiple other protests, all of which were rejected until 1972, when he deliberately leaked information on the Tuskegee experiment to a reporter named Joan Heller of the Associated Press. A day after it was first published, the story became front-page news in the New York Times. Congressional hearings were called, and the study was ended shortly afterward. In 1973, Congress held hearings for a class action lawsuit on the behalf of study participants. 1 year later, a $10 million settlement was reached out of court. The U.S. government also promised lifetime medical benefits and burial services to all living participants of the study, and the Tuskegee Health Benefit Program was established to provide these services to remaining survivors and their immediate family members, many of whom had been infected with syphilis unknowingly. Ultimately, the study caused the death of 128 participants, either directly from syphilis or from complications related to the infection. Hundreds of participants went on to infect their wives, many of whom passed it on to their children at birth, again, unknowingly. On May 16, 1997, President Bill Clinton formally apologized to the Black community, especially those in Macon County, Alabama, saying, "What's done is done and cannot be undone, but we can end the silence." Our guest today, Dr. Tina Sachs, wrote an op-ed piece for CNN where she describes the harmful, lasting effects of the Tuskegee syphilis study on the mistrust that many Black Americans feel for the healthcare system, and a lot of that lingers today. Dr. Sachs is a professor at UC Berkeley's School of Social Welfare, and her research focuses on racial inequalities in health, social determinants of health, and poverty and inequality. Her CV includes publications that have appeared in incredibly powerful and impactful public health and social welfare journals, CNN, Reuters, The New Yorker, and many other really influential outlets. She has a book out now titled Invisible Visits: Black Middle-Class Women in the American Healthcare System. She's an incredible researcher with a very interesting perspective, and I'll link to her page so you can all review her amazing work if you're interested. But without further ado, I'd like to introduce today's guest, Dr. Tina Sachs. Welcome, Dr. Sachs, and thank you so much for being on the podcast today. I'm super excited to interview you.
Thank you.
If you don't mind, I'd love to start by having you tell our listeners a little bit more about yourself and the research that you do.
Sure. Thank you. So let's see where to begin. So my research is really about the intersection of race, class, and gender and how it affects people in healthcare settings, just in general. My interest in that really comes from my own experience as a human being, and particularly being a woman, and the ways that women are affected by healthcare. Women's bodies are so, We are very vulnerable to the vagaries of medical care, being given that we often have to interact with the medical system a little bit more than people who are cisgender males. And my work also stems from my mother's experience with breast cancer and how she was initially, her concerns about a lump that she had found in her breast were initially kind of dismissed by her healthcare provider. And she really had to advocate for herself very strongly to get a biopsy and then to get subsequent medical care. And that really started my particular interest in healthcare.
And that's such a difficult thing for people to do, because I feel like we're especially taught to we're taught to trust medical professionals, right? And trust their opinions. And so there's this huge power differential in who has the knowledge, right?
I certainly have had my own experiences, like all people do, going to the doctor. And I think especially as a woman and as a Black woman, I have often felt that I haven't been taken seriously myself, that even though I have a lot of education, I certainly don't have a medical degree, but I really understand. I've worked in medical settings for a long time at the Centers for Disease Control and Prevention, and I do have an understanding, kind of generally, the vernacular and the vocabulary of medical care, and I have often felt kind of dismissed or just not taken seriously, or this person doesn't know what she's talking about. And of course, you never know why that is. When I was young, maybe it was because I was young, or maybe it was because I was a woman, or because I was Black, or certainly all three of those. Mm-hmm. I think interacting with reproductive healthcare is always really, really challenging. It's fraught with all kinds of stereotypes. And so I certainly can relate to that experience. And in terms of the women in my study, many of them had great experiences going to the doctor, but others had experiences in which they really felt that their pain was minimized, that their overall well-being was sort of like, well, whatever, you can just deal with it. I had one woman in the book who told me an experience that she had where she had these small tumors in her knee. She didn't know that. She kept going to the doctor because she was having knee pain. And she was quite young. She was in college at the time when it started. And then it went on for many, many years, 15 years. And they kept telling her, oh, it's because you're fat. You need to go to physical therapy. You need to do this. You need to lose weight. And then you won't have knee pain anymore. Turns out that she had 2 slow-growing tumors in her knee. And if they hadn't caught them when they did, because they had been growing for 15 years, she would have had to have her leg amputated from the knee down. Oof. But they did catch them, and she was able to just have a surgery to remove them. At any rate, the point of that story was that she was never taken seriously, even though she kept telling them, I'm in pain, and I don't think it's my weight. I've always been active, et cetera, et cetera. So kind of the devaluing of a person's experience, as well as not appreciating what it means to be 20 years old and to deal with pain for 15 years, and the kind of how debilitating that could be to a person's life. So those are some of the stories that really stand out to me.
It feels like that's often what you hear in the success stories, is that someone was really persistent until they were taken seriously. It's horribly unfortunate that they have to be that persistent, but maybe that could be, I don't know, a takeaway for our listeners too, is that if you know that something's wrong, persistence might be, key to getting something taken seriously.
No, absolutely. And I think the bottom line there is to trust yourself and to keep speaking up.
Yeah, that's a great message. Love that. Mm-hmm. I read an article that you wrote about implicit bias, and I thought it was really helpful for me personally. Could you talk a little bit more about implicit bias and racial inequity in healthcare?
Sure. So implicit bias is really something that it's an idea that came about, or that first really started to become something that people were interested in the research community after a seminal study, a very important study that was conducted by the Institute of Medicine back in the early 2000s. And in that study, the study is called Unequal Treatment, and it really catalogs, describes, and documents how people are discriminated against in the healthcare setting based on race, gender, immigration status, and language, disability, all kinds of dimensions. And they suggest in that piece and in their research that one of the reasons that there is so much discrimination in the healthcare setting is that providers they don't want to be biased or hold racial animus or other forms of stereotyping or discrimination against their patients, but they do, and they often are not aware that they hold these feelings, and so that's why it's called implicit bias.
Right.
And this is something that's taken up a lot. There's a lot of currency for that idea in the research community. I am a little bit less of a fan of that idea because I think many of the biases that people face in general in society are quite overt and explicit, and they're not implicit. And so I am not too much of a fan of that as an explanatory model, to be honest.
Okay. Could you tell us more about what you what you prefer in terms of terminology, but also in terms of like what do you think is going on?
I actually think that the biases are more overt. And I think that one of the reasons that they are more explicit, it's not to suggest that there are not implicit biases, because we live in a society that is just sort of rife with stereotyping and all forms of prejudices. And so certainly that is present. But I think one thing is important to note, and possibly, like you mentioned in the setup for this conversation, one of the things that you're trying to do is to uncover some of the history of medicine. Yeah. And the history of medicine in this country and the medical industrial complex is one in which thinking that people or treating people differently based on their race is on purpose. It is not implicit bias at all. Yeah. It is something that medical students are trained to do. And so that when we see differences in treatment, it's not surprising, because many medical schools and medical students are trained to treat people differently based on their sex, gender, race, etc.
They're trained to make these sort of judgment calls that are based in bias, right?
Absolutely. So, for example, I have had the fortune of working with some medical students at the University of California, San Francisco. And they started a group. They're all young women, and they organized a group to try to understand more about how they were being trained, because they had some very troubling experiences. For example, one of them told the story of going around doing rounds with an attending physician, and they were asked to kind of like pull out their whatever app they're using now as their physician's desk reference. And in this app, it actually said, this is something from 2019, that Black people have longer legs and shorter torsos than non-white people, and therefore you have to think differently about their lung function.
Oh, God. That's a really disturbing thing to hear from 2019.
Exactly. And so this is something that is happening all over the country in medical schools. And so it's when you see differences in outcomes based on race, it's not surprising, given that this is still how people are trained.
It's really unfortunate. Do you think that medical schools, and not just medical schools, because it's not just doctors perpetuating these things, probably it's members of the healthcare team.
Yes.
But do you think that those training settings, do you feel like now they're doing a better job of helping people understand bias? Do you feel like there has been progress made, or do you feel like it's kind of stagnated?
I think there's certainly some progress, and this group of students is an example of that progress, a group of students who took it upon themselves to say, this doesn't make any sense, both from a human physiology perspective. It doesn't make any sense, and it also doesn't make any sense that we would treat someone based on such an erroneous idea. And they came together and said, we want to change it.
Yeah.
And they have been active in organizing with other medical students at UCSF, as well as other medical students around the country. So there's definitely some progress being made.
Good for them. It's unfortunate that it has to be on the students to make those proactive decisions, but that's how things end up going a lot of the time, right?
That's right.
I want to transition a little bit because I read the case study that you conducted with the Tuskegee Syphilis descendant.
Yes.
And this episode, I wanted to focus on sort of the different ways that people are treated differently.
Mm-hmm.
But one of the things I wanted to focus on is the idea of the Tuskegee Syphilis study and sort of how that's contributing to modern sort of mistrust of healthcare.
Mm-hmm. One thing that's very important to put into context here, and thank you for this question, is the Tuskegee study is really an exemplar. It's a very powerful example of the kinds of persistent mistreatment and undertreatment, lack of access to treatment that Black people and other racial minorities have faced in this country for many, many years, for decades, certainly.
Absolutely.
So the Tuskegee study it encapsulates many of the challenges. Number one, I think something that's really important to point out about the Tuskegee study is that purpose of the Tuskegee study was to prove, quote unquote, the notion that Black people were fundamentally different biologically than white people. Yeah. And that goes back to what I was saying even about the different physiology, right? That idea, which is actually called scientific racism, that idea goes back for generations. And so that was the point of the Tuskegee study, that the federal government set out to determine whether the course of syphilis was different in Black people compared to in white people. To do that, they had to withhold treatment from Black people. And so beginning in the study began in 1932, but beginning around 1943, I believe it was, penicillin was available. They could have treated these men, and they did not treat them.
Right.
And many of them died as a result of advanced stage syphilis. And so the study went on for 40 years, right? So this is really an example of withholding of treatment, as well as the idea that Black people are somehow biologically different than white people. And that is just not the case. And that level of mistrust, the idea that the federal government would allow people to suffer in that way, is something that is not lost on racial and ethnic minorities in the present. And it is also just one example of that kind of withholding of treatment or mistreatment.
Yeah. In the history of our podcast, we've done lots of different episodes that have highlighted the idea that the federal government for a really long time was very much okay treating people of color like they were not people.
That's right.
As unfortunate as that is, and as disgusting as the history of that is, I can fully understand why it could contribute to modern mistrust of healthcare.
Yes.
Because historically, no one's been given a reason to trust the healthcare system in the U.S.
That's right.
The study that you conducted with the Tuskegee Syphilis descendant, what was your takeaway from that experience?
I think what I was really struck by was the long-term effect on her family and on herself, that what happened to her great-grandfather had such a profound effect on her life. It created a deep-seated fear of medical providers, and she also described withholding or not wanting to consent to a necessary treatment, a necessary surgery for her daughter. So what really struck me about that is just the harm that was caused to this person on an individual level, and also as a human being, as a mother. She really lamented, and she was worried that she might have made the wrong decision if she had withheld consent for, an appendectomy. And what if something had happened to her child? And then what if that was on her head too? She was really deeply emotionally affected by something. And I think when we talk about these issues, we tend to think about them in the abstract or theoretically, and this really hurt her. And that's what really struck me about her experience.
I read this term recently, generational trauma.
Yes.
Like a sort of passed down, internalized fear of, healthcare and participating in healthcare because of what happened to her, to her family member.
The trauma is real. And it goes to what I think also needs to be acknowledged, that people have been harmed, and that harm needs to be acknowledged as real harm, as opposed to like, oh, it's in the past, don't think about that. Because I
Right.
think that's sort of how we tend to try to minimize people's experience. And that's what her story really raised for me, that we
Yeah.
need to honor this pain and apologize for this and stop doing it.
Yeah. Yeah. I guess stopping would be the first step. Acknowledging
Yes.
and then maybe stopping would be ideal.
Yes. Yes, absolutely.
I read the CNN article, the op-ed piece that you wrote about how you think that that's contributing to modern mistrust of things like the COVID vaccine, and justifiably so.
Mm-hmm.
But how do you think that as a country, as contributors to the healthcare system, how can we do a better job of sort of repairing that relationship?
So I think that, again, like most things in this country, there's so many tentacles to it. There's so many pieces to it. And I think that, one of the ways to gain people's trust is to actually actively treat people as though they are people and that they are worthy of of an ethic of care, of love. And I think that in this country, we really don't do that. We don't do that across the board. We certainly disproportionately behave as though we don't care about the lives of people who are non-normative in some way, whether that's because of race or sexuality or whatever.
Yeah.
So one of the ways that we could actually start, I think, repairing that relationship is to stop doing harm in the present, because we are still actively harming people in the present, right? And so we have to actively stop the harm.
Yeah.
And then we have to repair the harm. And whether that is through reparations, whether that's through actually funding the public institutions that we need to be healthy, like housing, food systems, childcare systems, as well as healthcare and hospital systems, we have to do that first. We can't talk, I think, amorphously about mistrust without ceasing the harm and then repairing the harm.
That's a really good point, because I think that a lot of people don't think of social determinants of health, right? Like you were saying, housing, childcare, all of those things make a person able to get the healthcare that they need, right?
That's right. And it enables them to be as healthy as they need to be. I mean, one of the things that we know very much, there are just reams of data about this, is the way that residential racial segregation harms people's health. And so if we really want to talk about a healthcare system that we can trust, we need to also look to the social environment as a major determinant of health, and stop hurting people, stop forcing people into substandard housing, et cetera, et cetera.
Right. Yeah. I mean, like you said, there's a million examples of the federal government, of the healthcare system giving people a reason not to trust them. But how do you think that those things kind of translated into modern interactions with healthcare?
So certainly these stories are passed down from, family to family, friend to friend. And, one of the reasons I think that Black Lives Matter is such an important slogan is I think that people really do get the sense that their lives don't matter.
Yeah.
And that's when they interact with healthcare systems, or when they interact with school systems, or certainly the criminal legal system. You're sort of living it all the time. And then you also hear very distinct stories from family members or from other people in the community about how they weren't treated well in a healthcare institution. And so that certainly would corroborate someone's own experience, right? Of just their general life, and then also their particular experiences in healthcare settings.
That makes complete sense to me. People tend to trust the lived experiences or the oral history of someone else that much more than they would trust, a public health slogan that's like, hey, you should trust us now.
That's right. That's right. Yeah. I think acknowledging that this was done, that these things were done, is really important. And I don't think we actually have truly acknowledged as a society the kinds of mistreatment, experimentation, and withholding of medical treatment that has taken place. So that's a huge part of it, is to acknowledge that.
I think you're absolutely right. And I think that's a really good point, that acknowledging is definitely the first step.
Absolutely.
And I feel like you're completely right that we have not done that as a country and as a healthcare system.
You can never talk about anything in the United States, I think, without thinking about how racism affects everything, how gender, how sexism and misogyny affect everything. But you also have to think about capitalism and the fact that the healthcare industry is, a multi-trillion-dollar industry. It's almost 20% of our gross domestic product. And so it is necessarily, it's a money-making entity. It's a machine. And so it's not about an ethic of love and care or healing. It is about making money, frankly. And that's why there's a reason that I think that people haven't heard of HeLa cells, because it's not in anyone's vested interest that someone really know how extractive and exploitive the healthcare system really is.
Yeah, that's a really good point. Aside from like student activism and things like that, have you seen any recent changes, whether they're like policy changes or otherwise, that you think are moving in the right direction?
I think there are a lot of calls to address, like a lot of policy calls that I've seen to address the Black maternal mortality issue, at least in California. And I know on the national level, there are a lot of bills that have been bandied about to, provide some additional services to Black women, to work in Black communities. But I think that those are all really important in any kind of intentional effort to address racial inequities in health. I'm all for it. I also, because I really know that what all of the research says is that the social determinants of health are really what we really need to think about. And in the United States, we tend to devalue the social safety net, so food stamps, housing assistance, et cetera. And those are the kinds of policies that I would like to see us focus on, because we know that compared to other industrialized countries in Western Europe in particular, that we spend a lot of money on healthcare and we don't do very well in terms of health outcomes compared to those countries. And I think that there's definitely some evidence to suggest if we actually invested in our social safety net, we would do better in terms of health.
I'd like to kind of open the field and ask if there's anything else that you would like to talk about or like to communicate to our listeners, because I think you have a really interesting and cool perspective, and anything you want to get out there.
Oh, thank you. I think one thing that I have been thinking about a lot lately in terms of my general field of racial inequities is something that the pandemic, as well as the issues that we're seeing in Texas, these are things that I think are really important for us to address. And the connection, I think, between the pandemic and what's happening in Texas is really the issue of climate change as it relates to human health. And I think the pandemic, I think it's pretty clear that it was a disease, it was a zoonotic disease. It was a disease a virus that was in an animal population that jumped to a human population. And that some people think that that's because of habitat destruction and the fact that we're living so much more closely with animals because we're, destroying where they live. And I think what's happening, clearly what happened in Texas and the power grid and the housing, the weather issues, these are all things that, at least 58 people died there of what happened, not having power, et cetera. And this is something that I think we need to take really, really seriously from a human health perspective, the climate change issues that we are seeing and we're going to continue to see. And that climate change issues and the way they affect human health are going to disproportionately affect the most vulnerable people anyway, right? And so all of these issues are issues of health equity, and I think we would do well to consider them more explicitly in that framework.
Most people are thinking they're two separate issues. They're completely independent of one another, and you're absolutely right. And we've been dealing with the effects of the winter storm in Texas this week, and it was really devastating to a lot of people. I mean, more than half of the city, we're up to almost 8 million people in the city, and more than half of the city didn't have power for almost a week. And when you think about people who are, who have oxygen machines and things like that, like those are the people who are being most affected.
Absolutely. And again, you see where all of these issues intersect around disability rights and disability justice too. There's so many things, they're all interrelated, but I do really think that as a matter of urgent health equity, that the climate crisis is something that we really, really need to think about as a public health issue as well.
Yeah, I think that's a really interesting perspective that I haven't heard or thought about, and I'm very surprised that I haven't. But that's really cool.
Yeah, I hope. I mean, maybe you'll have some other. I mean, this is just my own kind of reading of the tea leaves here, but there are people who think about this much more closely. But I think it's something we really need to talk about.
That makes complete sense to me. If you could communicate one thing to listeners in terms of how to better advocate for themselves in a healthcare setting, or communicate to providers about like what their patients need from them, what do you think that would be?
One of the most critical aspects of this is time. And unfortunately, in medical settings in the United States in particular, time is really a hot commodity because we are always rushed and providers are always rushed. But what time allows is for deep, active listening. And I think for providers, that's one of the things that they may be able to improve upon. And I do understand that they are under deep constraints given the time issues that they face, but to actually listen and try to respect what the person knows about their own body as they are inhabiting that body, and they don't have specialized medical knowledge, but they do likely know themselves, and to really respect that knowledge and to treat each person as a credible witness to their own lives and bodies and experience. And I think that's really important for the provider side. On the patient side, I think knowing, certainly being able to convey what they know about their own body is really important. It does take a certain kind of skill to do that not everybody is going to have, but everybody knows their own body. I really believe that, and to try to convey that to their provider, and to respect that the provider has a certain body of knowledge, obviously specialized medical training, and that they are human and fallible. And so that when you go to the doctor, you listen to them and you take in what they have to say, and then you must ask questions. You must try to get your point of view across, even though there is inherently a power differential between a provider and a patient. But to try to hold both of those in your mind at the same time, that this person does have specialized knowledge and they're a person just like you, and so to approach them as a member of your team as opposed to your boss.
I think that everyone can do a little bit better. I mean, even me, like you were talking about your mom's experience, but we've all been through it where you go to the doctor, and if you go to a doctor who's especially, kind of controlling of the situation, you don't ask the questions that you came in to ask. You don't voice your opinion as loudly as you might if someone was doing a better job of sort of sharing that power with you.
That's right. It's a vulnerable experience for everyone to go to the doctor. And I think if we, as a society had a lot more of an ethic of love and care as opposed to power and, punishing people, I think we would all be better off. And we can all work toward that future. One of my favorite scholars, her name is Ruha Benjamin, and she always says a different world is possible.
Oh, that's beautiful.
Mm-hmm.
Thank you so much for being on the podcast, and thank you for sharing your perspective with us, and thank you for all the work that you're doing, because it's truly incredible, and I think you're making a big difference in the world. So,
oh, thank you so much. I really appreciate that. I've really appreciated talking to you, and I can't wait to listen to the other episodes. And thanks for doing this work.
Thank you. Thank you. This was awesome. If If you're interested in reading more about Dr. Sachs or her research, I will include in our show notes a link to her bio from UC Berkeley, and I'll also include links to any of the articles she's written that were referenced in this episode. If you like what you're hearing, please remember to rate, subscribe, and review us on Apple Podcasts, Spotify, Stitcher, or wherever you like to listen. You can also find us on Facebook, Instagram, and Twitter at Malpractice Podcast. And don't forget, malpractice makes perfect.